There. Well, welcome to our speaker, Timothy Klein, Dr. Kelm. Thank you. And so tonight, my head is kind of half off here, so that's okay. I am going to admit another person. Okay, Joan is here. And I'm just going to introduce Dr. Kelm and talk a little bit about his background. And he will be discussing neuropathy tonight and the available treatments, what is new in the science, and various levels of evidence that they have discovered. He will share how this relates to Lyme disease and the treatment options available through Realife Neuropathy. Dr. Timothy Kelm conducted the initial applied research that led to the development of the Realife Therapy. Through over 6 years of development, he identified the variables involved with the application of a class 4 therapeutic laser to treat the particularly complex biology of peripheral neuropathy nerve damage. Dr. Kelm was crucial in designing the therapy to consistently relieve the pain, we could use that, numbness, tingling, burning, and balance issues of this chronic condition. He is also actively involved in managing ongoing applied research in the treatment of the neuropathy and other chronic pain conditions. Dr. Kelm is responsible for training of all the relief franchise providers nationally, and he is an experienced lecturer on the treatment of peripheral neuropathy with the Realief system to the public, as well as clinician and research groups. So thank you, Dr. Kelm, for taking the time to be with us this evening. And if you have a question while the presentation is going, you can go to chat and raise your hand, and we will try to answer your question in real time, because it might be pertaining to a slide that is up. And so that might be easier to understand and to get through our questions. So write it in.
Yeah, and they should type the question into the chat, just because that's a little easier.
Yes. Typing and writing, they're two different things, I suppose. Okay. Everybody's got their mute on and their camera off. And so we will have Dr. Kelm begin. Welcome.
All right. Well, thank you. Thank you. Happy to be here. And if you can type the question in the chat, it's kind of a smaller enough group that I think if something comes to mind and you have a question, then probably other people have the same question, and we can get to it kind of as we're going through things. All right, let me get this started here. So peripheral neuropathy, it's kind of a broad category, and it's the broad definition of it is something wrong with the nerves that are outside of the brain or the spinal cord, which are your central nervous system. When we use the term peripheral neuropathy in the clinical setting, we generally will mean this damage process that starts at the ends of the nerves, usually at the longest nerves that go down to the toes and the balls of the feet, and then works its way on up. So when we say peripheral neuropathy, we mean typically the damage that starts at the ends and comes up. And of course, there's many other different kinds, but we're talking about the ends up. And that's the type of damage that happens with Lyme disease sometimes. Available treatments, something that's relatively new, different options for people. So what is peripheral neuropathy, right? We have these two general classifications, within the nervous system. You've got your central nerves, your brain and spinal cord, and then all the other nerves in your body are peripheral nerves. And they do talk to each other, right? The peripheral nerves here in the hand, they're sending the signal that this fire is hot up to the brain. And then the brain will send a motor command, or, tells the tell your hand to move away from the fire, right? So you got the sensory stuff coming up, and then you have the what's called the motor function, going down out from the brain. And so if you have disruptions within those pathways, you can get all sorts of issues, right? You get your motor and your sensory. And so peripheral nerves are damaged. They'll generally start at the ends of the nerves, and the longest nerves are the ones that go from your low back area all the way down to your toes, and then they work their way on up. And then after a certain point in time, as the disease progresses, then it's very common to get the hands involved as well. And so some of the most common symptoms where this starts generally down in the feet is people will remark that they felt like their sock was wadded up, or they have this thick sensation. They go check their shoe, and there's nothing going on there. That's pretty common for the start of this. I'll typically see, we've treated, this is all we've done for 16 years, and we exclusively work with peripheral neuropathy damage. I'll typically see that the autonomic nerve damage, the chemotherapy induced, and then the Lyme disease, they do tend to be a little bit more on the pain side, although there's generally numbness and there can be balance issues as well. But the ends of the nerves are damaged, and then it works its way on up. The diagnosis, there's a variety of ways to do that, right? Just take a general history. Do people have the risk factors for the disease? Lyme disease, at least nowadays, I think more than ever, even more than maybe, 10, 20 years ago, I think it's pretty well known that you can get complex, unusual symptoms and a lot of neurological symptoms. I work with peripheral nerves, and there's definitely some central nerve issues that can happen with it. It's all kind of mixed together, it's all one nervous system. Blood tests, right? That's more for diabetes or vitamin deficiencies. The electrodiagnostic testing, where they basically hook you up to some pads or stick a couple needles in the muscles and run a current through it to check the transmission of the nerve impulses. MRIs, they're going to look for actual physical things like impingements where things are squishing the nerves. The damage that happens with Lyme disease, it's not compressive. So there's nothing squishing the nerve that can be surgically unpinched, like carpal tunnel in the hand. You can surgically release an impingement or where it's getting contacted or compressed, and you can release that impingement. And the type of nerve damage that you would get with Lyme, chemo, alcoholism, what have you, it's non-compressive, and that's why there's no surgery for it. The biopsies are typically used if other things are negative. The electrodiagnostic testing is really only good for your large diameter fibers, which are more on the numbness, weakness, balance side of things. And the biopsy, they'll count how many nerve fibers are in that skin sample to look for what's called small fiber damage. Although by the time you're typically to that stage, it's just confirmatory because you've ruled out everything else, but it's still useful to be done. Autonomic testing, those check how responsive the blood or the body is to where it should be changing blood pressure and things like that for what's called your autonomic nerve involvement. So there's a lot of tests that can be done for peripheral neuropathy. They usually lead to the same interventions regardless, but if you do have questions about, if you do have some symptoms and you haven't been diagnosed, there's definitely options to be diagnosed. The thing that happens too is there's this massive idiopathic population where, as much as you hear about diabetes and peripheral neuropathy, there's probably about as big a large a population that has peripheral neuropathy without diabetes. And it's very common in the population in general. So, but there are things to do to get checked out. And probably some of you, if you do have these symptoms, have had several of these already, I would assume. Having the Lyme disease diagnosis and then you start to have neurological issues, that's pretty suggestive of peripheral neuropathy already. So Lyme disease in particular, so it can, there are estimates and, there's ranges for everything, but, maybe, 15% or so of the Lyme patient population. It's probably low. I would say that's probably low from what just in my experience, because there's a lot of undiagnosed Lyme sufferers. And of that population, you know, there's quite a few even diagnosed Lyme patients that aren't diagnosed. But let's say, you know, 15 to 20%, 1 in 6. So diagnosis from the history, and then there's co-infections, of course, and the co-infections to the Lyme also can contribute to neurologic symptoms. There's a lot of things that damage these nerves, and any of this peripheral neuropathy, it's just some damage process. It could be multiples at the same time, damage these peripheral nerves beyond a certain point, and then the condition is basically its own condition, and it tends to be progressive afterwards. So once it starts to a certain degree, oftentimes it's its own condition, or you should consider it its own condition. You know, these are some of the other causes. This is from the Foundation for Peripheral Neuropathy, which is probably aggregate a lot of the etiological, you know, information that's out there now. They have a lot of endocrinology clinics that they sample from. And so, you know, they have the, you know, 60% of the population is diabetic. I think that's very much overrepresented just because they have a lot of endocrinology, like diabetes specific groups that they sample from. You know, in our population is all self-selected patients from all different etiologies that are coming in. And it's probably the diabetic is maybe about a third. And then another third is idiopathic, which means they've got all of this, you know, almost identical damage, all the same symptoms and everything as everybody else. You just can't get a cause. Chemo is another big one that we do. And then you generally have all the other causes. And Lyme is right in there. Some damage process that goes beyond a certain point, and now you have peripheral neuropathy. I've had some unusual ones over the years as far as like a physical damage process where somebody had progressive neuropathy, injuries, failed back surgeries, some freezing, some contractors where they got shocked. You know, you die if you're electrocuted. So they told me I was shocked I wasn't electrocuted. And then one of my most interesting one is I had a gentleman who was gored. He was gored in the thigh from a buffalo on his buddy's buffalo farm. That was enough trauma to start off the peripheral neuropathy in his feet, and then it worked its way on up. So something causes it, and Lyme is certainly a cause. But it could be multiple causes as well. And so, Gail, I can't see if somebody does have a question or something. So if you just unmute and just stop me and ask the question, that would be perfectly fine. So what causes, yeah, I'm sorry.
And I will have, okay, these questions are from Karen Vakota.
Lyme causes mononeuritis, multiplex, multiple small nerves inflamed, and long-term nerve function fails. Does laser help this?
And then the next question. Well, we can just do it.
Sure. So some of those things kind of in that sort of vein, to me, a lot of that, it would fall almost under the autoimmune type category, right? And so you have like, if you have something similar to the large fibers, that's like a chronic, you know, demyelinating polyneuropathy. It's sort of where the body's attacking itself. We do treat, we treat, it's probably in that smaller population, like the Lyme disease patients. But the autonomic damage responds almost identically to the other damage. So yeah, we treat autonomic peripheral neuropathy as well. It does definitely, I've noticed that ones like that, they do tend to be more in the painful aspect of it, which is, you know, that's not great, but we typically, some of these like really hardcore large fiber issues where they have a significant amount of muscle atrophy, we have to help that nerve function, and then they have to rehab it. So like some of the more painful ones are actually a little bit more straightforward to work with.
Lyme is actually the small nerves.
Yeah, the small nerves, sure. Yeah, the small nerves, I mean, there's usually not a lot of rehabilitation, like rebuilding the body position awareness, what's called the proprioceptive rehabilitation and things like that. So usually they just got to show up and sit in a chair. So it's actually a little bit more straightforward for them.
I have a question.
Yeah, go
on
ahead.
the
Autonomic.
autonomic neuropathy, because I was reading the list of different symptoms that you could have with that, and I have several
Yeah.
of them. Like the swallowing issue, the urine incontinency, the shortness of breath, the high blood pressure, the dizziness from getting up and getting down. And so, like, I started looking at that, and I'm like, I didn't really understand. I knew that all these things were happening to me,
Yeah.
but I didn't really realize that it was possibly part of what that is. So is that something that you deal with, like with all those other issues that start going into the different organs?
Yeah, so the autonomic neuropathy, and there's the autonomic nerves that control, those nerves are throughout your body as well, right? So they go into the organs, and they're also heavily, they're through all of your extremities. They're in the skin. I mean, they're everywhere. They're what controls your hairs standing up when you get cold. They're responsible for properly constricting and dilating the blood vessels, so you get good perfusion out to your feet. That's another thing with this neuropathy business is people start to get discoloration in their toes, and they think they have some sort of blockage or some sort of blood flow issue. It's actually the autonomic nerve damage. There's like parasympathetic and sympathetic. Specifically, the sympathetic damage that's causing the body not to control those blood vessels correctly. And so you can get, like, we were running some testing on patients, and a lot of them had some vascular abnormalities, and that's due to the loss of the peripheral control of the blood pressure, right? And so some of that, like, postural stuff where you get up and you start to feel dizzy and things like that, there's a lot of different causes for it. But if we're looking at things through the lens of neuropathy, the neuropathy can cause a delay in the proper, like when you stand up, the blood vessels constrict in your legs to keep the blood up in your brain, right? And if that's not happening correctly, you can get some lightheadedness with that. So we've absolutely seen improvement in those autonomic symptoms, like the postural, right? The postural sort of blood pressure issues. We certainly see a dramatic increase in the skin quality as the peripheral neuropathy gets better. So yes, the autonomic nerves, you can look at that objectively and see that those things are responding. As far as the vagus nerve directly, right, a cranial nerve, it's interesting because we've worked on people's, faces, right? And a cranial nerve is coming right off of the brain or right off of the brain stem. So that's technically, those are, I would, those are central nerves, right? They're right off of the brain, brain stem. And we can get the facial, so people will get facial, basically like a neuropathy, right? They respond great. Those are really short nerves. They tend to respond really well. The vagus nerve itself, as far as some of those, I don't know if I have a solid answer for you. We've definitely seen that we influence some of that postural, like lightheadedness, dizziness due to blood pressure abnormalities. I don't have enough data or enough testing to say whether or not that's affecting the vagus nerve itself. That's a 10th cranial nerve. Certainly the 5th cranial nerve that goes into the face, sure, we're pretty confident about treating that. So I guess if directly vagus, that would be a maybe. Skin perfusion, blood perfusion, some of that postural sort of blood pressure issues, sure, we've definitely seen that. Direct vagus, I guess I can't give you a great answer. So that's maybe the best answer I can give you right now.
Well, thank you. What about,
Welcome.
have you seen the COVID-induced neuropathy, Dr.
We
Vercote?
we absolutely have. Yeah, we have it. So it's any any damage process that goes beyond a certain point can cause the neuropathy, right? And with the COVID, depending on its severity, of course, you've got this huge inflammatory condition, and the pathology of neuropathy itself, and one of the reasons why when it starts, it's self-perpetuating and it keeps itself going, is it has an inflammatory component. And so we have a lot of our patients that once you get ahead of the nerve damage, you actually do have to maintain the condition. So they'll have to come in a couple of times for like a single like touch-up visit, and then, you know, they stay in good shape. And so we've had like nice, stable maintenance patients that have been stable for years and years, and they come in and they have like trackable damage up their legs again, you know, and they had COVID, and it was bad enough, you know, that it actually sort of caused that damage. And we have several people now that are in care, in initial care and in maintenance care. They were bad enough to be hospitalized, and they came out of it with neuropathy. So anything that's tough enough on the nerves, if it gets past a certain point, can cause neuropathy.
Okay, thank you.
You're welcome. It looks like I could click on this little meeting chat and see that.
Mhm.
Oh, now it went. Now I lost it. Oh, I'll leave it up. Okay. So what causes these different symptoms? And we did touch upon it just now. It's basically which types of nerves are damaged. And so on this little chart here, you've got this, we see this axon, and that's kind of the wire, right? If you want to think of this almost like an electrical wire, you know, that's kind of like a wire that carries the signal. And then some of the nerves have like this insulating sheath around them called a myelin sheath. And so you have the ones that have the thickest myelin sheath. Those are your fastest nerves, and those are responsible for touch sensation, right? So feeling the texture, you know, of the carpet, or, you know, their touch sensation, and they do body position awareness. So your brain knows where your feet are if you're not looking at them. So if these nerves are damaged, that's, you know, the people that have the nummishness, and they start to lose their balance, and it directly controls the muscles. So numbness, weakness, and balance if the larger fibers are damaged. The middle one, they have a thin myelin sheath. Those are responsible for hot and cold sensitivity. And so if those are damaged, then you can either start to become insensitive to hot and cold, or you actually start to get what are called like hot and cold dysesthesias, where, you know, your feet feel like they're freezing, but if you touch them, they're really not. Or maybe your feet, they're slightly cool, but they feel like they're ice to your brain. Or the opposite, where they feel like they're burning, and clearly they're not burning. And then the lucky people, they actually feel like they're burning and they're freezing at the same time. So depending on the degree of damage to those nerves, that's the symptoms that you get. And then the bottom one right here, this little one, the only thing that tells you about is pain. And so when that one's damaged, it starts popping off pain signals when it's not supposed to. So depending on which of those nerves are damaged to which degree, those give you your, you know, general, you know, smorgasbord of symptoms that you can get with neuropathy, and quite a bit of variation from patient to patient. You don't have to have pain to have neuropathy. Matter of fact, it's actually more common to have a non-painful neuropathy. So if we look at one of the most studied groups that have neuropathy, which is the diabetic population, you know, maybe about 2/3 of them, they don't really have a painful neuropathy. They might have some low level of discomfort, but it's mostly the balance, the movement, not knowing where their foot is on the gas and the brake, those type of quality of life issues. And of course, there's no medication for numbness. So just wanted to throw that out there. If you don't really have a lot of pain with your neuropathy, you're not some sort of unusual case. I will say in general, though, Lyme patients, just like the autonomic damage or the autoimmune type ones and chemotherapy, they do tend to have a little bit more pain than some of the other groups. So, okay, move on. There's other symptoms. This kind of gnarly picture is what we want to see after supper, right? It's a cadaver with the skin taken off. And that white filmy stuff that's on there, that's what's called fascia. It's a connective tissue that's kind of over everything. And then you can actually see some of the nerves in there as well. But the fascia, the autonomic dysfunction, we're kind of back to those autonomic nerves, the same ones that control your blood flow. When those nerves are damaged, it actually tightens down this fascial layer. And so people will feel like they're tight and stiff, and it feels like my socks are too tight, or it's like a shrink wrap, like my foot was shrink wrapped. And so there's an actual physical tightening of the fascia in response to the autonomic damage from the neuropathy. So you'll see the nerves control everything. And so when the nerves are damaged, you get all sorts of crazy symptoms. So there's a lot of tightness. And as a matter of fact, as we reduce the nummishness and that numb sensation from the neuropathy, that tightness can actually become more people can become more aware of it, you know, because some of the numbness was actually covering it up. But that tightening of the tissues, specifically in the fascia, it's called, super common. I mean, 98% of the people that I'll see will have that to varying degrees. And that can be a big symptom by itself. So we talked about, we were kind of touching this a little bit. Since the autonomic nerves that can get damaged from the neuropathy control blood flow, you can get some swelling. And it's not caused, there's a million different reasons for swelling, right? But if we're only talking about neuropathy, you can get an edema or a swelling from that sort of improper control of the capillaries and all the blood vessels down there in the feet and stuff. It's called a neuroedema. So an edema or a swelling from neurological cause, not from, you know, like congestive heart failure or something like that. You can also get a neuroischemia, which is a reduction in the proper oxygenation of the tissues. This is secondary to the autonomic damage, right? Anybody that wants to sell anybody something for neuropathy says, well, it increases blood flow. Like it's not a blood flow issue. Any sort of ischemic or like poor blood perfusion is going to be secondary to the neuropathy itself. So. And then some of that orthostatic tachycardia, like you were talking about, like where you get up and you feel lightheaded because your body's not responding to the blood pressure demands like it should. So you get a lot of other symptoms from it. It's not just pain. You know, the neuropathy, it's not just pain. I actually see more people on a day-to-day basis where the movement problems, the balance, the mobility is actually more of an issue than the pain. So there are available treatments. There's the medications, right? Lyrica, Neurontin, gabapentin is the generic of Neurontin. And those are like anti-seizure medications. They're kind of like epilepsy medications. And they're trying to slow down the incorrect firing of those pain fibers, kind of like in the, you know, like a seizure in the brain, you get this incorrect firing of the neurons. And so, and they can take the edge off of some of that pain, which is a blessing. You know, the Elavil Effexor, some of these like anxiety type medications are used for neuropathy to increase people's pain threshold, right? So you can tolerate the pain a little bit better. You know, OxyContin and some of the opioids, you know, over the years, I've read a lot of stuff. It kind of goes back and forth, like they're useful, they're not useful. You know, it's like one of those things where it's worth a try if you get to that point. But like the OxyContins and those opioids are usually better for somatic pain, which is like slamming your hand in the car door or local back, or, you know, like low back pain and things like that. The neurogenic pain, it's called, from the neuropathy can be pretty tricky to treat. So lidocaine patches, I don't know. I haven't really seen a lot of people that have success with those. TENS, the electrostim stuff, that may be worth a try. It can sometimes temporarily disrupt the pain transmission. It's not curing anything. It's not healing the nerves. A lot of these things are worth a try. I just sometimes have a problem with the marketing that surrounds them. Surgery is generally not going to be a good option for this type of neuropathy because there's no pinched nerve. There's nothing being compressed, right? So it's a non-compressive type issue. Think of it more like cracks in the dam rather than a pinched nerve. Acupuncture biofeedback. I mean, I'm certified in acupuncture. I don't do it with my patients. I haven't really found that it adds anything to the end outcomes, but there really isn't any downside to it. You know, if something's going to happen, I would probably expect it, you know, 2 to 4 visits. You know, it'd be worth a shot. Biofeedback sort of similar to that. And everything that's out there is only focused on pain because, of course, you can't numb numbness. You know, there's no medication to numb numbness. This is another thing that happens with the neuropathy. And so what this is this is a slide of muscle tissue. So if we took a chunk, this is, you know, somebody that has neuropathy, if we took a chunk of muscle out of their foot or their leg and we looked at it under a microscope, this is what we would see. Now down at the bottom left, this is how big around your muscle fibers should be, okay? And then sort of in the middle-ish right area, you can see these smaller ones. Here's a section that has basically been shut off by the neuropathy. They're not dead, they don't go away, but the little nerve that would tell these muscle fibers to contract, it's not able to, even though their neighbors can. And so they're shut off and they atrophy. And this is one of the most frustrating things with the neuropathy, especially for the people that have some weakness and balance issues, is that they're going to have, they're going to have some limited amounts of improvement from things like physical therapy, or like their well-meaning people say, well, get out and walk more and you can rebuild that strength and balance. With the nerves not allowing these areas to contract, they'll be working on their neighbors, but these can't contract until you can actually improve that nerve function. So now we see we have another physical component secondary to that nerve damage, right? We've got the autonomic stuff like blood pressure and blood perfusion, maybe some swelling. We've got that tightening of the tissues, and now we have direct sort of basically shutting off bits and pieces within the muscles themselves. This one's very common as well. You can help to improve the remaining function with physical therapy, but if you could actually improve the nerve function, then you could start to rehab those weakened areas. And so that's kind of our goal with what we do. PT, I get the supplement stuff, alpha lipoic acid, acetyl L-carnitine. Those are worthwhile. You know, they're amino acids. Your body metabolizes them into antioxidants. So again, you're lowering the inflammatory state of your body, which is good for your, not only the neuropathy, but your general health. It's one less thing to irritate the neuropathy, right? It can make you more comfortable. I've never seen it reverse the neuropathy, but they're cheap. They're good for reducing your inflammatory state. And the same with fish oils, right? It's another good antioxidant, reduces your inflammation. Magnesium, people tend to be a little bit low on magnesium. That's a super easy thing to supplement. It's super cheap, worth a try. D3, right? We're all deficient, unless we're, you know, generally in the Midwest, we tend to be deficient in D3. Low risk, worth a try. Don't overpay for them. You can get them in any pharmacy, you know, CVS or anything like that. Soft tissue mobilization, that can be useful for that tightening of the tissues. Our brains, you know, they can feel if that contracture is tight. That contracture tissue can actually contribute to our subjective sense of even that kind of numbishness, that numb clunkiness that people can get. Some of it's actually coming from the nerve damage, and some of it's actually coming from that tightened tissue. So it's a lot of it's just in the skin. So like a traditional massage has a tough time stretching it. There's actually like a particular way to stretch that out that we teach our patients to do. But like tissue mobilization, it won't help the nerve function, but if it can help stretch out that tightened tissue, you can get some symptomatic relief with that. So what do? We've been doing it for a while now. So we use what's called a class 4 therapeutic laser, and there is absolutely no neuropathy laser, and there's no neuropathy setting. There is a therapeutic window as far as the dose goes. That seems to be the key. And then, yeah, mobilizing that soft tissue, and then once you improve that nerve function, then that's the time you can actually work on the strength and balance. So there's kind of an order that things should be done in. All symptoms, right? So it's not just the pain side. Like I said, I don't want to like gloss over the pain, because the pain can be pretty debilitating. But the strength and balance and the mobility and your ability to drive, I mean, that's a huge quality of life issue as well. So I kind of put the larger fiber stuff, you know, a half a notch ahead of just the pain. But we can't treat one and not the other. So it accelerates the body's ability to do what it wants to do anyway, which is recover that nerve function. You know, and we'll see, and possibly some of the folks here or people that you know with Lyme disease, you know, when they're acutely having an attack, right? Or initially when they start to have all of these symptoms flying all over the place, they'll get some of these neurological symptoms. And then when things get under control, or maybe they're treated a little bit more effectively, they'll notice some reduction in those nerve symptoms. That's the body actually recovering that function. So it's trying to. It's just this current neurological damage is beyond its ability to cope, and the relief therapy can help give that a push in the right direction. And the only thing that matters is if there's a measurable return of function, right? So we talked about there is no magic neuropathy laser. There's no magic neuropathy setting. I get 12 things. There's also more baloney out there than I've ever seen before in the last 16 years. But there's a dosage window that you need to be in, right? And if you're within the therapeutic window, then you're going to get the physiological changes we're looking for. If you're too high or too low, it's not going to hurt you. It's just going to be a waste of time. And then actually, if you kept on stimulating somebody, there's an inhibitory window where you actually start to slow down some of the processes that you want to enhance. It's unique to each patient in that we're all different sizes and shapes, right? There's no one size fits all. And as these nerves improve, they get better from the top down. So if you reduce the surface area of the patient's problem, you can't keep doing the same thing over and over again. So that's different, not only from patient to patient, but that's different as they actually progress. Therapy treatment system developed from 40,000 treatments. That's probably significantly higher, 70 or 80,000 at this point. But in general, right, we had to go through a lot of data to figure this out. And so we actually have an issued patent on it for that reason. This is kind of a little bit of a simplified sort of, this is kind of what their light therapy does. It's mostly photochemical. So there's an interaction with what are called chromophore molecules on the cells. So these are light sensitive cells, and it increases the permeability. It just enhances the body's ability to do what it's trying to do anyway, which is recover that nerve function, right? With the correct dose, that's true. There are different kinds of lasers out there, right? There's some different classes. They don't really have any clinical studies with efficacy. You have to have a class 4 at least, but you generally need to know what you're doing with it more. There is no neuropathy laser again, right? We've used several different kinds over the years. Fortunately now our treatment algorithm and our software controls the lasers and does all of the calculations internally, which is a big time saver for us, but there is no specific laser. They're actually very similar. You just have to know what you're doing with them. Treatment itself, that's kind of a good example, right? You know, you're sitting in the chair, therapist works on you. This is some of the ways that we first had to figure out how you measure this stuff. And so here is a patient that's, you know, he's okay. Look at how old that example is. But anyway, he gave us permission to use some of his data in 2015. Gosh, that doesn't seem like it was that long ago, but it really was. So for him, for his initial, some of his initial information, he actually had a distinct, it was really hard for him to feel any vibration up into the thigh, all the way down into the toes when we first saw him in his initial evaluation. He started to have some degree of numbness and a tightness from the knees on down. And then he had an inability to feel like a pinprick type sensation from about the knee on down as well. This is a pretty significant case of neuropathy. And he also had some substantial balance issues at the same time. So after we get his neuropathy under control, you know, we can retest these things, and then we see that he just has a bit of a vibratory loss. He does have some numbness left in the toes and some degree of tightness, but he has a large recovery of function and a much improved quality of life. So, right, we had to figure out how do we quantify this sort of nebulous nerve damage in a way that we can actually track it. Right, in response to the relief therapy, right, we get better from the top down. It's just the way the nerves work. They're these huge, gigantic cells, and their nucleus or their factory is way up top, and the toes are at the end of the supply chain. So, kind of the opposite direction as the loss of the function. There is a specific way that we get that tissue tightening. That's pretty common, and there is a specific way to stretch it. It's not like a deep tissue thing. This fascial tightness is actually more of a pain in our rear end than the actual neuropathy itself. So if somebody's a patient, they hear quite a bit about that. It might not, depending on what your symptoms are, you might not be aware of that until you start to reduce the neuropathy itself. So yeah, it affects a lot of things. You know, it affects the nerves, but the nerves control everything. If you improve that nerve function, you absolutely can improve your strength and balance. We'll show you how to mobilize the soft tissues, reduce the falls risk. It's a huge fall risk. Functional independence, quality of life, maybe being able to not think about your feet all the time. Maybe, you know, walking across the hardwood floor without having slippers on, being able to sleep at night. Have the sheets touch your toes, you know, all of these things that we took for granted before we had neuropathy. I like when people will tell us that they're feeling better, but the best thing to hear is, you know what, I just don't think about my feet anymore. It's very similar to before they had neuropathy. That's kind of the best thing. We'll just have a couple real brief other cases, and you can kind of see, you know, we're going to measure people. These are sort of Lyme specific. This is a gal, she had it 9 years, right, since the onset. You know, we take a look at where people can feel vibration and pinwheel correctly, because vibration is carried in those big fibers that have to do with numbness, balance, and your muscle strength. And your ability to properly perceive the pinwheel, that's in those smaller fibers for the pain and hot and cold stuff. And the interesting thing for any clinicians that are listening is that an oversensitivity to the pinwheel is actually a mild damage compared to the insensitivity. And once you start not being able to feel the pinwheel, that's typically enough damage for people to get these hot, cold, or pain sensations. Before that, just where it's overly sensitive to the pinwheel, that'll just start to disrupt some of their ability to feel hot and cold. So that's a little tidbit that's not in the literature. And now you know it, and your cohorts don't. But anyway, this is where she started off with. She did have some hand involvement, which about a quarter of our patients do. By her third visit, she actually had a pretty significant drop, right? We can see that a lot of that sensory abnormality that was about mid-shin is now focused more towards the front halves of the feet. And let's see, about a month in, she was doing pretty darn good, just some intermittent type symptoms. And you can see that reduction in surface area. By her 14th visit, she had just some limited difficulty feeling the pinwheel under her toes and a little smidge of numbness left under the toes, and then some residual sensations of tightness. So, yeah, not too shabby. She'd had that for about 9 years. So that's actually a little bit of a slower progression for 9 years since onset, and it dropped down quite nicely. This is typically close to what we can get most people to, you know, a little bit of dullness under the toes and some residual sense of tightness, but that's very livable. Oh, I guess she had it for 14 years. Tingling, numbness, burning, right? Weakness, balance concerns. This is very typical of a lot of our patients that come in. Third, end of initial care. She actually did have some tingling left underneath the toes, but it's interesting, right? Sensations decrease with soft tissue mobilization. The tightening of that fascia that we talked about can give you a tingly burning sensation, just like the neuropathy can. So that's interesting. There's a lot of overlap between the sensations that people might feel from the tightening of that fascia, that connective tissue, as with the actual nerve dysfunction itself. Oh, I see we got a chat thing. Once improvements occur, do the improvements stay? So you cannot cure the neuropathy, unfortunately, and once it starts, it's its own self-perpetuating type thing. So it's like we tell people, like, right where the toes meet the balls of the feet, that's where the neuropathy starts. If you look at the nerves, it should start at the very tips of the toes, but it doesn't. It starts right where the toes meet the balls of the feet, and there's like a little hole there that the water is going to come into the boat. We do have to see patients like a couple of times a year for like a single touch-up-y type visit. So yeah, you do have to maintain it. You know, you can't cure it, but once you get ahead of it, the maintenance is not that big of a deal. And I mean, we've had patients in maintenance for, you know, a decade and a half. So it has to be maintained. It's not that big of a deal. But yeah, you do have to touch it up periodically. Good question. I'm sure other people have the same question. Right. This is Jill. You might know her. 14 years since onset. Again, we see once it's bad enough that we're tracking some sensory abnormalities towards the knees, we get a lot of patients like that, right? She has a lot of pain, right? Has a hard time falling asleep. Her feet feel like blocks. These are very common presentations that we'll see with patients. What did she do? It's been a little while. 2019, look at that. End of initial care, again, some kind of numbishness just underneath the toes and some small residual inability to feel the pinwheel. This is a cool one, huh? Able to work a full 8-hour shift without foot pain. I believe she's a nurse, so they are on their feet quite a bit. better have some clinical evidence of these things. So this is an aggregate of several thousand patients. Most people experience symptom relief. We sort of have this aggregate non-responder rate of around 7%, as long as there should be a real good candidate. And then most people get a reduction, you know, again, most people, it's pretty good. A little bit weird underneath the toes is pretty average. This sort of says the same thing. You guys are unfortunately in all other causes, and you get significant reductions as well. This percentage is by surface area, and what this group is they have a smaller surface area to begin with, so they actually end up in about the same spot as everybody else, which is, you know, a little bit of weirdness left underneath the toes. We did the study with the U of M. They did everything. We just actually technically treated the patients. And this was all on chemotherapy-induced peripheral neuropathy, which is kind of a little bit of one of the harsher ones. We did, for the people that joined us a little bit later, on our end, treating the neuropathy for 16 years now. The damage, regardless of the cause, is almost identical. And so we actually don't see a difference treating toxic, alcoholism, chemotherapy, Lyme disease, physical trauma, et cetera. But this one was specifically on chemotherapy. And this is out of the gynecological oncology department at the U of M. And unfortunately, some of the chemotherapies that are best for treating ovarian cancer and uterine cancer, breast cancer, are also really neurotoxic, and you're almost guaranteed to get neuropathy with them. And yeah, so we had a crossover group. It was double-blind, placebo-controlled, right? The U of M did all of the work. They said it was one of the fastest enrolled studies they've ever had, with the highest patient compliance, right? 97% of them in the treatment group and 100% in the sham group completed more than 95% of their scheduled treatments. And this could have been over an 8-month period, because the people that were in the placebo group, we did treat them afterwards. There were no complications or adverse side effects. We did have somebody in the sham or the placebo group. We did have an adverse event, but it was in the placebo side, where we had to create a little bit of warmth without using the laser. So she just dropped her leg on the little heat probe and got like a little tiny burn. So I think that's funny. It's so safe. There was an adverse event in the study, but it was in a placebo group. We have a question here that says, does it occur usually in both feet? And then how does it affect the hands? It's a really good question. Does it occur? Yeah, typically. I mean, half the time it's going to start on both sides at the same time. And maybe probably a little bit over half. And then sometimes it just starts on one side. And then as it progresses, well, then it sort of ends up in the other side. And then, how in the world does it affect the hands? So we have to think it's not jumping from one foot to the other, and it's not jumping from the feet into the hands. We got to think of your nervous system as one integrated system. And we're even artificially separating it. Well, it's the peripheral nerves and the central nerves. It is one system. And so if you think about it like a plant, right? If a plant you can't just affect one part of the plant, right? It's eventually, once these roots start to shrivel and then these other roots start to shrivel, the reason that it will typically take a little bit longer to affect the hands is they're shorter nerves, right? The nerves are these big, giant, long cells. Remember, they come from your spinal cord and they go all the way to your fingertips, and the ones from your low back and your sacral area go all the way down to your toes. And so they're these big, giant, long cells. The shorter the nerves are, right? And the hands, the ones to the fingertips, are shorter than the ones to the toes. The shorter they are, the tougher they are, and they can hold out against that damage for a bit longer. So 9.5 times out of 10, it's going to start in the legs. And then by the time the patients have some suspicion or, of just even some mild symptoms, maybe about halfway up their shin, that would typically be about the time it starts in the fingertips, because they're shorter nerves, so they're a little bit tougher. So hopefully that answers your question. If it doesn't, then go ahead and ask me another one. Right. So these are just some of the bullet points, right? Is that with what we do, we can treat more than just pain, right? And the cause of it doesn't seem to matter, thank God, because half of our patients don't even have an identified cause. you get symptom relief no matter how long they've had it. And this is a question that we get, is age a factor, and is it a factor how long I have it? And I would say for the age aspect, it's probably a lot less of a factor than it is for like darn near all the other conditions. We have people that are in their 90s that do phenomenal. The only tough part when they're in their 90s is if they have a lot of weakening of the muscles. It is harder for them to kind of rebuild that stuff. It takes longer. But otherwise, I mean, they do just fine. Yeah, it doesn't matter if you're on many of the medications or if you're not. There really hasn't ever been any adverse events. And the symptom relief can be maintained for a lifetime, right? But you do have to have a bit of maintenance every once in a while. So here's a question that we have. I have strong numbness and tingling in my hands, not much in my feet. Does that indicate a particular cause? That would be really odd if it was like a boring old diabetic one, but Lyme disease is particularly weird, right? And so is it when you say your hands, is it all of your fingers too? Or is it just some of your fingers? Because what we do when we're looking at these patients is, you know, you can have other things going on other than neuropathy. So there's no law that says you can't have neuropathy and herniated disc or sciatica, or you can have neuropathy in your hands as well as carpal tunnel or ulnar nerve entrapment or brachial plexus entrapment and all sorts of weird stuff. Intermittent, but mostly in the middle finger. So that would be it's in both sides fairly symmetrically. Yeah, so that would be slightly weird. And so you would look at that, and your doctors would look at that, right? And they would say, like, well, you know, those middle fingers, I joke that it's an overuse syndrome, right? You're just using them too much, haha. So a lot of the doctors would think, okay, well, that's just their middle fingers. So that must be coming from her neck, right? So that's coming from the neck, but to have that symmetric, like it's the same side to side, if it's coming from the neck, then you have some sort of nerve pinch, right? You know, between underneath the 7th cervical vertebra. For that to be symmetric side by side would be very unusual. And we've had, we've had these things that look dermatomal. So they look like they're coming from a nerve root, and they're actually peripheral neuropathy. They just, for whatever reason, are affecting, in your case, like that 7th cervical nerve distribution. So slightly unusual. That's kind of the nice thing about, like, this is all we've done for 16 years, is that we've definitely seen things like that. And we would want to be able to track the same sensory abnormalities that I showed you before, so we can quantify those things and we'd be able to march those down. So yeah, that's a little bit of a more interesting one. But you know, the Lyme is so bizarre. You know, the most bizarre ones, diabetes is boring. Which is not necessarily a bad thing for those patients. It's going to affect people relatively the same. Autoimmune and Lyme disease, you get these sort of oddball presentations, and so you have to have an open mind to it. So, yeah, we've seen that stuff before. So, question: frequency and cost of treatments. Yeah, we have people that are traveling from about 16 different states last year. Cost of treatments, you know, we're probably around a couple $100 a pop. Can you do all the treatments in 2 weeks? We're open 4 days a week. You can plow, so you could get 8 done in 2 weeks. That is a pretty significant chunk of initial care. We will be able to re-examine our patients generally after a visit or 2, and we have to see that we're getting that recovery of function, okay? So like for those patients that you saw earlier, they couldn't feel, you know, vibration appreciably below mid-shin. We would honestly want to see that probably about halfway down to their ankle in about a week or so. So you can get a lot done in 2 weeks. And we have a lot of people that are traveling from all across the state or even out of the state. If you need somewhere to stay, it's La Quinta. I'm a barbarian though from Wisconsin, so I call it La Quinta. They have a reduced rate for our patients. And so for the people that are a long ways away, sometimes they will come in and they'll just pile in some treatments, you know, go home for a little while and come back and knock them down. In the maintenance phase, it's very easy because there's, you know, there's a decent amount of time in between. So yeah, we can qualify people a lot because we do see people from hours away. Just let the front desk gals know And if you look like a good candidate, we can knock out a treatment there. Sometimes we can actually re-exam by the next day. Certainly after 2, I need to see that there's a recovery of some of that sensory dysfunction. So within a couple of visits, we can definitely see if somebody's responding. Good questions. Okay, yeah, you got to maintain it. This is just an independent evaluation of our registry data. Remember, we've got tens of thousands of treatments worth of data. And she is, you know, way more accomplished than I am, and all she does is statistical analysis. She used to be at Mayo. She got poached by somebody else, though. Statistically significant improvement across all 8 measurements of neuropathy signs and symptoms, right? And what statistically significant means is that it wasn't chance. The interesting thing, not statistically significant, was balance. This quality of life functional test that we did wasn't really captured with that. And so the statistical improvement with balance, that has to be accompanied by this. This is an evaluation of initial care. So you have to get that nerve improvement first, and then you can rebuild it. So this data for these patients, you would probably need about a 6-month follow-up to check on the balance itself. But during initial care, which is just several weeks, we get the nerve function first, and then you got to rebuild that balance. So for us here in Minneapolis, this is all we do is work with peripheral neuropathy. It's myself, I've got a doctorate nurse practitioner. We are a study center with the U of M. We do train the other clinics, and this is all we do. I mean, we have staff members with peripheral neuropathy. Like I said, we do have a patent on this. Oh, look at this, Justine. So she says, I can share that I've been going to Relief for well over a decade for my neuropathy, and it's helped to keep my activity level up. It is an investment. The alternative is not great. Hi, Justine. I won't officially say that I know you. I thank you. Oh, look at that. Hi there. I don't really do much Zooming. I saw that name and I thought, well, I may or may not know a Justine. So officially, I don't know you, but it's lovely to see you, whoever you are. All right, so now we have more time for questions. So it's been working well to just type them up. Or if you would like, I can stop sharing my screen. Maybe that'll help. And then I guess, Russ, I'm not sure when will the recording link be available? I'm not sure.
Dorian, do you know when it will be available? The recording link? Okay, Dorian might not be here.
That's okay. I'm assuming they'll email out the link to everybody involved as long as they have their contact information. So here we have a question. Her dad.
Okay, go ahead.
I'm sorry, this is Dorian. Yeah, in terms of the recording, usually because we have it go to the cloud, so usually by the next day we'll get something, but then we have to send it to our web people. So it could take a couple days. So it should be there within a week.
On our website.
On our website. So that's where you can, at mnlyme.org. And we do not post it to YouTube. It's just directly on our website.
Thanks, Dorian.
You're welcome.
Yeah. Well, and like I said, like we were saying before, you know, the causes don't really seem to matter since the damage ends up about the same. But we do have a question about, my dad is 82 years old. He does not have Lyme, thank God. He's got a lot of foot edema. They're huge. And that's, you know, so that can be a lot of things, swelling, congestive heart failure, lung stuff. As we get older, the one-way valves in our veins start to get a little bit leaky and we get some swelling. Although if we're looking at it through the lens of neuropathy, you can get some of it from the neuropathy. He has intense burning at night. So when you can have pain and burning with swelling because you're stretching the tissues and you're stretching the fascia, and you can get burning from that. It's the same like when you do like the snake bite thing. If you are the older sibling, you did it to somebody. If you were the younger sibling, you had it done to you. The burning is from stretching the fascia. So he could get that burning from that. But what he says is his burning is at night, primarily at night. So increase in symptoms and pain at night is very common with neuropathy. It goes back to so that, to me, one, his age, and this neuropathy stuff is just so darn common. And the fact that it gets worse at night is suggestive of neuropathy. He has scoliosis, so right, we're thinking, does he have any back involvement? That would be like the back involvement, it would be very unlikely for it to be symmetric. And the neuropathy itself doesn't have to be symmetric. It could definitely be worse on one side or the other. Scoliosis, though, I mean, that would be more like a piece, like it would be like his right big toe burns. It wouldn't be like his whole foot. And the neurologist has him on Neurontin because that he or she knows that it's nerve pain, and that doesn't help. Either it's because it's not nerve pain, or it's because the Neurantins, Lyricas and stuff help about half of the patients get a 30% reduction in pain. So that to me would be worth an evaluation. You know, we would want to be able to track that sensory abnormality like we were showing before, and then within a visit or two, we need to see that it's dropping. If that's not dropping after a couple of visits, then we do discontinue care. If it is dropping, we just get this giant reduction in surface area, so it's very clear whether somebody's responding or not. So hope that answers your question. Here we have a question. I have tingling and pain on my left hand side only. Scalp affects your ability to sleep. Scalp pain. Well, we talked about that, and I'm assuming, you know, this came out. This wasn't some sort of traumatic injury, and you didn't have any other issue. This is sort of concurrent with the Lyme disease. Yeah, it's interesting that you know the head is like the fifth cranial nerve, right? We were talking about these different types of nerves, and yeah, I wasn't sure years and years ago. The like head stuff, it responds just fine. You know, it responds just fine. And you would look for that reduction in surface area. The weird thing about the nerves is that you can get that, when you're improving them, you can get a reduction in nerve in the surface area of the complaint. And that is one of the things we track the most, because it's just the way that the nerves work. They're these big long cells. And you can get a reduction in surface area and intensity. And sometimes you just get a reduction in intensity until you run out of affected area. So yeah, the head stuff doesn't really worry me at all anymore, right? That seems to respond pretty easily. They're really short nerves, and in general, the shorter nerves are easier to treat. Other than the pudendal nerves, which that area is like, you can get neuropathy where you sit on a bike seat. That's actually the only area that I've come across where those nerves, just because they're relatively short compared to the ones down into the toes, those actually need as much work as anything else. But usually like the head and the hands and stuff are a little bit easier. Do I post on YouTube? Nope, I don't. Sorry. This question, I have terrible foot pain, neuropathy, or is it musculoskeletal? Why can't it be both? Right? It could be both. It could be one or the other. Is, you know, terrible foot pain, is it, does it happen only when you're weight bearing? We'd have to pick that apart with generally within like a pretty quick history, we could get a real sense of that. A little bit of a history, do a little sensory exam, see if there's any sensory loss. For some of these things, if somebody has a lot of pain, well, the pain is your most noticeable symptom. But if you have any degree of numbishness or strength and balance issues, then that would definitely be suggestive of neuropathy. But you could certainly have multiple things going on in one area. A little bit of history, see if we have any sensory loss, something to treat, and then we could be pretty confident about whether we could maybe work with you or not. I mean, we do have to tell people sometimes that we can't help them. Intense back itching. The back would be kind of an unusual area. But like we said, neuropathy itself is pretty weird. Is it on both sides of the back? Is it the whole back? Is it something in a strip? That would be something that I would question. Itchy burning stuff can be in those small diameter fibers, so potentially. Palm itching, is it a symptom of neuropathy? Is it an itch that you can't scratch? If it seems like you can't actually scratch it, then it could be the neuropathy. Thank you. You're very welcome. I mean, the neuropathy is a really weird condition, and there's similarities, but there's also a lot of differences. And just for people to hear, you're actually in this giant group of patients. So there's tons of neuropathy out there. Better to do treatment at the beginning of symptoms. Yeah, usually, you know, earlier is a bit better. Makes it a little less complicated. I like to get to it. It's a little bit easier. Yeah, if it's a little bit on the earlier side. I mean, I had this poor lady that she had neuropathy. She didn't have an identified cause, but she had it for 46 years, you know, and we got her about 46% better, which is not as good as we usually do, but at least she could walk down the driveway and get her mail. So what is a session like? So we do a little evaluation. We'll actually come in and we'll hit the nerve roots themselves, as well as the areas that we're actually affecting, or that we're actually tracking damage in. So a visit, people are in and out in about an hour. Treatment itself is very gentle. There's no side effects. There are what are called recovery sensations, which think about those like when your hand falls asleep, it tingles when it wakes back up. And so the physiological effect of the laser on the tissues, again, with the proper dose, we talked about that. That's different from person to person. But assuming you're doing it correctly, there's about a 20-hour window in which you've got that positive physiological effect. And so the night of treatment, you could have a little bit of tiredness or little tinglies as stuff wakes back up. But you're in and out in about an hour, and then your body does the work over the rest of the night. Why would my full left side tingling get so much worse when I'm sitting? So either it's postural, right, which would be suggestive of some sort of structural issue, or when you're seated or you're kind of relaxing in the evening or at the end of the night. The neuropathy, it's very common for it to get worse in the evening. And to go back, we talked about those pesky autonomic nerves, right? Hold on, I gotta take a little drink. All I do is talk for 10 hours during the day, and then I'm talking now. So, but anyway, so in the evening, like we've got the autonomic nerves that control everything automatically, stuff we don't have to think about. And you've got two sides of it. You've got the sympathetic side, and when that's damaged, that's where that tightening of the tissues comes from and like blood flow issues. And then you've got the parasympathetic. And during the day, you get much more like sympathetic autonomic activity. And then in the evening, we start to switch to the parasympathetic as our circadian rhythm, we're kind of getting ready for bed. And for whatever reason, that switch in the autonomics from, you know, less sympathetic and more parasympathetic ticks off the pain fibers. So it actually is very common for people's symptoms to flare up when they're off their feet at night, which is sort of counterintuitive. Sometimes it tends to isolate people because it's tough to explain this to other people, and it's tough to explain to them, even maybe a spouse or loved one, you know, you're off your feet, how can you feel worse? And, you know, I thought your feet were getting numb, how can you be in pain? So it's really a bizarre thing. So we have a question here, is restless legs part of this? True restless leg syndrome is central nervous system mediated, like the brain and the spinal cord. But your lower motor function, right? That's all peripheral. So it's interesting over the years, and we don't really specifically track this, but we definitely have people where they have restless leg type symptoms, and it gets better as we get their neuropathy better. In which case, that's strongly suggestive that you actually had this peripheral motor nerve involvement, right? Those large fibers, right? Those thickly myelinated, you know, alpha fibers. That they are, well, actually, that would be, yeah, just the large diameter fibers. That those were damaged. So it may be, right? I'll say maybe. But true restless leg is brain and spinal cord. But we've had people that were diagnosed with it that get better as well as their treatment gets better. Website for Relief is, maybe I'll type it here, www.relief.com. So it's supposed to be like real relief. So yeah, reliefcenters.com. Anne says Lyme disease is really bizarre. It is really bizarre, you know, but it's bizarre. Like, it's known that it's bizarre. I think it's hopefully a little bit better known how bizarre it is. And so your practitioner, anybody involved with it, and I'm not a Lyme specialist, all I do is this neuropathy stuff. Like, you got to keep an open mind to things, especially when you have some of the ones that are a little bit weird, like Lyme's disease and like some of these autoimmune type ones. So it looks like, oh, I'm just sending it to one person here. Let me send it to the group. Everyone in meeting, we'll give the website here. And there is like a doctor's blog thing on there as well that that talks about some of the oddball things with the neuropathy. Especially, I think there is, actually I know there is, there's a thing about the autonomic consequences of it, which is sort of this hidden thing. Somebody earlier was saying that they maybe weren't aware, you know, that some of these other issues could be related to the nerve damage. All right. So any other questions that people have, feel free to type them in. You're welcome, Justine.
All right, if we could all unmute and put our camera on so that we can thank Dr. Kelm with a round of applause, that would be wonderful. We got one more question there. Do you see any
Oh.
autoimmune diseases that cause more neuropathy issues?
Yeah, I mean, you can have, yeah, sure. They would be autoimmune like specific though. So you wouldn't have something like rheumatoid arthritis, you know what I mean, that would cause the neurological issues. But here's the thing, you can have rheumatoid arthritis and other autoimmune things. You can have rheumatoid, you can have idiopathic neuropathy, which means you have peripheral neuropathy and you can't nail down the cause, and you also happen to have rheumatoid arthritis. And sometimes when you have autoimmune issues, you have more than one autoimmune issue, right? So just because you're specifically diagnosed with a specific autoimmune issue doesn't mean that you don't have something that's affecting the nerves as well. So we have to be a good clinician and we have to keep our minds open. And the doctors are they're very much like everybody else, where they're looking at something and they're like, okay, well, we want one tidy diagnosis that accompanies everything. And life is just a little bit messy with that. So yes, there are definitely autoimmune diseases that cause neurological issues. But like something specifically like RA, that won't by itself, if that makes sense.
Wow, this has been really fun and very educational and I think really beneficial to our Lyme community. And I'm so happy that you reached out to us and wanted to share your knowledge and your professional expertise with us. We really appreciate that.
Hey.
Sure.
Thank
Sure,
you.
my pleasure.
Thank you very much.
All right. Well, thank you everyone for coming. Remember that we will have support group in July, second Tuesday of the month at 6:30. You'll get a Zoom invite. And anything else, any other announcements that anybody would like to make? All right, it was great to have so many people here and thank you so much for coming. All
All
right,
right, thanks all.
and then I just stopped recording, right, Dorian?
Hit stop record.
More.
Okay, hold on.